In the last lecture, we talked about transference towards the group as a whole, subgroups in between members. This talk, let's focus on countertransference. So countertransference was identified by Freud in 1910 as the unconscious influence that the patient has on the analyst and the analyst's or therapist's reactions to the client's transference. Over time, and particularly due to the kind of clinical contributions, I'd say, of object relations and the other relational theories, the ideas and definitions of countertransference have evolved and has become more broad to include basically all conscious and unconscious reactions the therapist has towards the client. Currently, countertransference is not seen as only inevitable, but potentially helpful in the therapeutic relationship. All therapists will have countertransference reactions towards their clients if you are alive, if you are engaged, if you're feeling in any way, if you're awake to what's happening inside you. Even if you're not awake to what's happening inside you, likely things get stirred whenever we're in the presence of someone else. So our feelings about our clients are not something to get rid of, but rather something to be studied for everyone's benefit. As leaders, we need to work towards recognizing and becoming curious about the potential meaning of our feelings and attitudes towards our members and towards our group. So I think probably the most revolutionary article on countertransference was by Racker in 1968, which many of you may be familiar with already. So he kind of broke countertransference up into kind of four unique perspectives. First, as a objective countertransference. So these are feelings and reactions that most people have towards a patient. These could range from either feeling excited, wanting to please them, it might be marked disgust, but it's a variety of potential feelings, and even I would go as far as kind of behavioral inductions that most people feel towards this client. In some way, there's a consensual validation that most people feel this way when they are around this person. Not everyone, but many people. I would have to say most, maybe upwards of 80% for it to be really objective countertransference. Then there's subjective countertransference. So this is the unique and idiosyncratic reactions based on the therapist's personal history, personality, past experiences. So this would not be shared with the majority of people, but somehow this particular person brings up something unique and personal for you. So you often hear about the differences between subjective and objective countertransference, and you'll talk about this in your group, you'll explore this with your groups. So Racker went on to describe two other ways that kind of view countertransference. One is concordant identification. So this is when you're having empathy, you're kind of having resonance, you're having feelings similar towards the client. This could range from outrage, this could range for enjoyment, but generally you're having a similar experience, feeling state as the client. Now this can be contrasted with complementary identification. So this is identifying with how other people in this individual's world may feel or want to act around them. This could be similar to the modern analytic idea of induction in some way. So there's potentially some split off part of the client's internal world that's kind of promoting people to kind of act in a certain way. Oftentimes these complementary identifications are unconscious in some way. While someone may try to act either tough or may try to act sweet, that there's some way that below the kind of drama the client is trying to play, there's a pull towards treating this client in a similar way as other people have treated this client, most likely formed in the early stages of this client's life. So I think using Racker's taxonomy allows group leaders to question how best to utilize one experience for the benefit of our members. A complementary countertransference may bring forth very strong impulses and inductions to react to members in ways that really merely reinforce their existing scripts and attributions. A more therapeutic view would be to understand and reflect on what we're pulled to do with the client, how that's reflective of their internal world, and what might be a more curative emotional exchange with the client. We want to find out ways to work also with our subjective countertransferences by studying them, by seeing if they are similar to the way the client describes how they've been treated in the past, and kind of taking it up with ourselves. What is getting resonant in us? What's echoing from our past with the clients? I think it's important not to shy away from acknowledging our feelings towards our members. At times, some members will bring feelings of dislike, distrust, annoyance. For other members, we'll have a pull to have friendships with them, to joke around with them. These are not character critiques of our patients, but they may shed light on the specific needs and fears that the members are experiencing in the moment. Often, if we feel ourselves tempted to act in ways that seem foreign to us, it might be best to ask ourselves the question, what role is this patient's history of interpersonal relationships am I invited to perform at this moment with this client? I think reflection, containment is always best if you find yourself strongly pulled to act in a certain way, to confront, to complain, to praise. Generally, the rule of thumb is to kind of review internally an intervention 3 times before giving the intervention. Now, this can't happen in group because sometimes you will need to step in quickly. But you can think about your inductions between group sessions, in supervision, and unless there's an emergency, you can study your countertransference reactions, try to make sense out of them before acting on them. I think what makes countertransference complex is that we're not blank screens. We do bring our own interpersonal forces to each situation. If we are kind of to make the maximum use of our affective emotional responses in therapy, it's imperative that we continue to develop sufficient self-awareness so we know that when we are being impacted or induced by others to act in a certain way, what's coming from our own historical background and what may be more being pulled for from the client. Group is great for this because to some degree, you'll be able to see subjective and objective countertransference in the way that the majority of the group members are induced to treat members. You'll also be able to kind of sort through kind of these concordant complementary countertransferences. Are other group members feeling similar to the client, or potentially are other group members acting in ways that early figures in this group member's lives acted towards them, and that subtly in their behavior, tone of voice, communication style, affective sharing, that we're getting pulled to play the other part of this client's kind of internal drama in the here and now. So it's often referred to as countertransference management. So that's not you're denying countertransference, you're managing it. It's an exploration, really, of one's own cognitive affective reaction to patients or potentially to the whole group. And you're trying to avoid being defensive on one hand, denying what's occurring on the other hand, and at the same time engaging, embracing, trying to learn from what is occurring in the group. So I think there's some helpful guidelines about how to manage countertransference reactions. So I think first would be kind of self-insight. This refers to the therapist's awareness of understanding their own feelings, attitudes, personalities, motives, histories. I think without a doubt, being a member of a group, doing in-depth, personal kind of psychotherapeutic work can help with this. I think mindfulness practices, particularly kind of, I would say, Vipassana practice may bring some more awareness to certain patterns of yourself. The second guideline here is self-integration, reflecting on the therapist's possession of kind of an attack, basically healthy character structure, and kind of to some degree trusting your instincts but exploring your instincts. The other views that would be helpful here is you need to have an ability to kind of self-mastery, anxiety management. So the therapist needs to kind of control their impulses, their anxiety, so not to become reactive when having strong countertransference reactions. I think empathy really helps with this. Our ability to identify, or at least partially identify, with our client, with how the client is feeling, what they pull for the ways for other people to treat them, I think can kind of give us breathing room and be more thoughtful and maybe more attuned to do something that is helpful in some way. Now, I think all of these kind of rely to some degree, although many are based in feeling kind of states of self-regulation or empathy, but I think bringing this cognitive kind of case conceptual ability to somehow take this piece of information of your countertransference reaction and put this into a understanding of the client from what you know about their history, their behavior in group, their goals for group, that having a framework for why you're feeling the way you're feeling towards this client will kind of help you, guide you on the possible ways to respond, including not responding to a countertransference. So there's some research that says competent countertransference management helps therapeutic outcomes. But I think for countertransference to be a productive part of treatment, the group leader needs to accept that we're having these feelings and that these feelings need to be studied. That I wouldn't call this just following our intuition, but having our intuition and then studying our intuition. I think we could ask ourselves these questions all the time as we're leading groups. What am I feeling in this moment? Where are these feelings coming from? Are these familiar feelings that are invoked in me in many situations? Or are these unusual feelings that are somehow potentially being brought forth by my group or a member of the group? Would other therapists feel similarly, or are my reactions kind of idiosyncratic and unique? You can talk about this potentially in group supervision or in supervision in some way to get other people's views. And then you have to ask your question, what do I want to do with these feelings? Would I like to share them in therapy and supervision, or is there a way that having these feelings can help me intervene in a way that would be helpful to the client? Like, could they serve as a groundwork for a potential question, an interpretation, or a steering of new experience for that group member in the group? Particularly in the frequent situation of complementary countertransference, we are invited to enact a particular role in relationship with our clients. Now, it is crucial that we do not impulsively do so. Although I might say it's impossible to not do that at some point. If feelings are being induced, we need to ask, what role in this patient's history am I being invited to perform? What does this desired role say about the internal world of the patient? Or potentially, if we're pushed to act a certain way towards a group that's unusual, what's this saying about the group members? What may need further exploration and understanding? The vital message here is not that we should avoid strong thoughts and feelings towards our group members, but that really we should welcome these strong feelings. Countertransference is another source of important information that can be used to understand your members in your group. Kind of the more deeply you can be open and accepting to what's occurring inside of you, I think this will help you be kind of more responsive and gain a deeper understanding of how to intervene with your various clients. So I want to say something here about a common countertransference that's found in therapists. Generally speaking, therapists, compared to objective measures, survey instruments, measures of, say, ego skills or ego strength, dramatically overestimate the progress in psychotherapy compared to these objective instruments. So in some way we have to try to find a way to track accurately, knowing this therapist bias, the changes in our client. So I think the goal of group psychotherapy, as with all modalities, is to affect psychological change or behavioral or lifestyle, personal growth change. To produce positive outcomes, we are increasingly kind of called to kind of look at what progress is actually being made. And I think with insurance, funding, grants, we need to continue to kind of document in multiple ways the progress of our therapeutic work. So therapeutic change, I think, can be viewed and assessed along a variety of dimensions, right? So this list could include working on the group members' personally defined goals. This could be increased self-esteem, less anxiety or less anger, something that the client is coming in saying they want particular help with. Sometimes this will match and overlap, and sometimes not, with basic symptomatic change. Someone may want to have less panic attacks. They might want to have a brighter mood. They may want to have less suicidal ideation. They may want to have less intrusive psychotic thoughts or some form of hallucination. They may want to have less kind of obsessive thoughts and compulsive behavior. So this would be classic DSM, kind of diminishing the intensity, the frequency of specific psychopathology symptoms. Now some clients want various things, and depending on your model and also what you're treating, psychological growth could look differently and could be kind of further away from a client goal or potentially further away from symptom reduction. Some clients want to remain sober, and while that's a long-term goal, there may be kind of steps in the path of achieving that goal. So this is kind of the difference here between treatment goals and treatment planning. So in this example, potentially developing a psychological vocabulary with the client, more mindfulness awareness of kind of internal somatic states that help clients understand triggers and cravings would be very helpful in this way. Some clients kind of want more general kind of ideas. They want increased insight, increased self-awareness. They kind of want to modify the ways they are in relationships in the world. Some clients kind of want more emotional regulation, or I have clients who say they want more emotional intelligence in some way. So I think you kind of work across spectrums here. I think you work with what the client wants. You work with your understanding of, depending on the insurance company, Western psychology, the diagnosis. And I think ideally you kind of work collaboratively to create goals that may meet the needs of the various stakeholders in some way. Now, some therapists are very interested in working towards client satisfaction, which can make them kind of placating, praising, and I think client satisfaction is important. It helps for clients to stay, but really I think the goal here is to have clients change in the ways they want to change, which is not often or usually a very satisfying experience. That in some ways you're disrupting patterns that feel uncomfortable, that there's a process of disorientation, annoyance, agitation, anxiety that comes along with therapeutic change. So as a group therapist, I think we're trying to track change for each one of our members. Now we can do this through clinical observation, through asking our clients, maybe having our clients informally, qualitatively document how they see themselves from time to time. And it can also be done through kind of formal objective survey instruments. So I think you want to try to assess, is therapeutic progress being made? Is no change occurring? Or potentially are signs of deterioration are present? Some clients do worse in certain types of psychotherapy. I'm thinking maybe deeply expressive kind of psychotherapy for people in acute psychotic states generally hasn't shown to be helpful in helping people kind of recover more quickly. So I think what dimensions a therapist chooses to focus on in terms of change depends on the various stakeholders, the client, insurance companies, your views, your collaborative process with the client. Now these might be different in different types of groups. So in an open-ended psychodynamic group, the therapist might choose to primarily monitor ideas like psychological mindfulness or shifts towards more resilience, choice, problem solving, kind of look for a decrease in kind of rigid or maladaptive defenses. Now, with the ideas of, say, cognitive behavioral therapy, you might be looking at different dimensions here. Are clients able to think rationally? Are they able to kind of notice when they're having some kind of distortion of their thought? Are their problematic behaviors decreasing? Are kind of helpful, pro-life enforcing behaviors increasing? So this would be kind of looking at the outcome of psychotherapy in some way. Now, I think another aspect that you can look at as you observe your groups, whether you do this qualitatively, kind of through your own analysis, through input of the group members, or through survey instruments, is what's happening in the process of group psychotherapy. I think the American Group Psychotherapy Association kind of created a battery to measure outcome and process. So classic outcome measures that may be used would be SL90, QC45. So they might be very specific, kind of the Beck depression or anxiety scales. But then there's also kind of process measures. So therapeutic alliance to the members, to the leader, a sense of cohesion, all those therapeutic factors is a way to measure that these are occurring in groups. So in the core battery I talked about, they kind of look at three factors which I kind of talked about earlier, deriving from Jennifer Johnson's work. So these are there positive relational bonds in the group? You ask your group members, how do you feel about the other members in the group? Is there kind of a I would say respect more than liking of them. Do you feel connected with them? Would be the more important question than necessarily having just positive feelings. The second question would be measuring positive working relationships. Do you feel that other members of the group are working collaboratively towards the goals of the group? These may be defined in a homogeneous group as symptom reduction or learning new skills, or maybe in a heterogeneous group towards various group members having various goals at the same time. And then the third kind of element you look at here is kind of negative factors. Does this group somehow feel non-therapeutic, harmful, shaming? Is a preponderance of kind of negative reactions occurring more often in group than, say, positive feelings? When people think about the group, the hope for change in the group, do they feel more negative about it than positively about it? So I think I want to talk a little bit about kind of an emerging field here, a trend, which would be practice-based evidence. So this is routinely administering kind of these psychological assessments and inventories to kind of assess the progress of each patient in the group. It is important to note that the use of instruments to kind of track therapeutic progress in group process have not been that common in practice. Some people feel that it interferes with the direct connection and communication to have someone fill out a brief survey instrument on their phone, say at the end of session. On the other hand, advocates argue that by administering these routine measures, say at the end of every group once a week, it will kind of increase the therapist's awareness of where group members feel like they are going, with kind of this would be an outcome measure towards the group, or you can also kind of measure the process. Are group members feeling connected to the group? If you're seeing someone's not feeling connected, you may miss that in your countertransference in the group, and they're more likely to report it on a survey instrument. This can really help, I think, with treatment planning, of bringing someone who may be a treatment failure back into the group, bringing them in individually to kind of reassess what's going on for the group with them. And I think you can bring this information back to the group in some way to try to get more information about it. You could potentially say, I wanted to check in who feels like they're getting something out of group, who isn't, what do people say if we try to work so everyone gets something out of this group. So I think having more information to kind of track potential failures or stagnations is a wonderful thing to do in group. And I think within the transference of clients often wanting to please the group therapist, they are less likely to say it in the kind of immediate dyadic dialogue, more likely to say it in their survey instrument. And that's what the research says on this. So I think this is something for you to think about, is finding a way to kind of measure what's going on in the group, and I think potentially recognizing potential progress biases of psychotherapists, and kind of looking at ways that you could get other information in reports. So we talked about survey instruments. Sometimes what I like to do, particularly if I'm working with a college student, and sometimes when I'm working with someone in a long-term relationship or a referral from work, I'll ask for a collateral contact where someone can, from the outside, the partner or the employer or a family member or a close friend, will be willing to kind of talk to me with a release of information about what they're observing in the client's behavior. I ask them to be very, very honest, and then I kind of get a sense of how treatment is progressing or potentially not progressing. So that's some thoughts on countertransference and some thoughts about tracking progress in group psychotherapy.